Friends, welcome to my workplace at Ranaghat, West Bengal, India. In this video, I want to show the benefits of large oval rexes. This technique has been described by Dr. Kiranjit Singh of Amritsar, India. By this time, the main incision and the left side port has been made, and now 2% HPMC is injected into the anterior chamber. The anterior chamber is filled up with this visco. Now one more side port is made on the right side of the main incision. The main incision is at around 11 o'clock and the side ports are about 2.5 to 3 clock hours away from the main incision. And now capsular rexus. See the large oval rexus. The anterior capsule is incised, a capsular tag is raised. Hold this capsular tag with the utrata forceps, come at 11 o'clock and go to 5:30 o'clock and come back and complete this large oval rexus. And now hydrodissection. Hydrodissection is done just as usual. BSS is passed just under the rexus margin. The nuclear mass tends to come up and fluid buildup is much less in large oval rexus. And now HPMC is injected again. The tip of the phaco needle is to be introduced into the anterior chamber, and now this is the phaco needle. The machine being used is Oatley Catarix 3. Some superficial cortical lens matter is removed. The nuclear sclerosis in this case is grade 2, soft cataract. So my plan is to do a mechanical job, one trench, then second trench, support the nuclear mass in irrigation and slice the nucleus with the chopper. So this is mechanical job. And now see the benefits of these large oval rexus. The nucleus tilts and whole nucleus tends to come to the phaco tip. So the followability of the nuclear fragments increases a lot because of these large oval rexus. And this is the last portion of the nucleus. Phaco power, that is ultrasonic energy used is 50%, flow rate is 45 ml per minute, vacuum is 450 millimeter of mercury, and now 2% HPMC is injected again, and see at this time the large oval rexus. The cortex is being removed with the 23 gauge Simcoe cannula through the main incision. Visco is there in the anterior chamber, so the anterior chamber is nicely formed. Most of the cortex has been removed, only the sub-incisional cortex remains. And now I take the bimanual irrigation aspiration. If we use Simcoe cannula, we give time to the assistant to get ready with the bimanual irrigation aspiration. Irrigation is through the right side port, aspiration through the left, and the sub-incisional cortex is removed very comfortably. And it is done. And now is the time to implant a lens. In this case we have selected this lens. This is Sensor single piece intraocular lens from Abbott Medical Optics, AMO, now Johnson & Johnson. And now the haptics are placed at 9 o'clock and 3 o'clock. where the capsular rim is thick and the thin rim is at 11 o'clock and 5 o'clock. This is moxifloxacin. The side ports are closed by hydrating corneal stroma on either side of these side ports. And now is the time to do the final lavage of the anterior chamber with the 23 gauge Simcoe again, and see what happens. The visco from the back of the cornea comes out at this time. The capsular bag is also irrigated and aspirated, and we are towards the end of the surgery at this time. The antechamber is nicely formed with BSS. Once this antechamber is nicely formed, we check the integrity of the wounds. There should not be any leakage from any side, and then some few drops of moxi is applied with the ocular surface and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. My aim in this video is to show the benefits of large oval rhexis. Fallibility of the nuclear pieces increases to a great extent just because of the large oval rhexis. Thank you very much for your attention.